Bismillah wassalatu wassalam ala Rasulillah. In this lecture we'll talk about breast cancer, and it is done for uncommunicable diseases course for undergraduate students. These are SLOs and the contents which will help to cover the SLOs. Incidence and risk factors of breast cancer. Breast cancer is the worldwide leading cause of death in women. 1 per 9 women will develop breast cancer, and unfortunately this is increasing. So maybe within few years we will have 1/7 and etc. Why? Because we have risk factors, and these risk factors actually are increasing. So the breast cancer risk factors can be divided into two types or two categories: non-modifiable and modifiable. Being a woman, being female, is one of the risk factor, and actually one of the non-modifiable risk factor. Age, ethnicity, family history, all of these are non-modifiable risk factors. For example, in the ethnicity, the white woman is at risk more than African woman, and the African woman has more risk than Asian woman. Early age of menarche, late menopause, and first live birth after age of 30. All of these are risk factors which we can relate them to prolonged exposure to estrogen. So the breast tissues here will expose to estrogen, and this will make the breast tissue at risk of malignancy. As early as we interrupt this estrogen by progesterone, especially before 30 years, this will decrease the risk. At the same time, if the age of menarche and the age of menopause become closer to each other, for example, this is the menarche and this is the menopause. If this period became shorter, this will decrease the risk, and if they increase, it will be a risk factor. Nulliparity also related to the estrogen exposure. Number of breast biopsies before, as long as the patient having previous problems in the breast, this will increase the risk of malignancy. And history of the precancerous lesions like atypical hyperplasia, lobular carcinoma in situ, all of them are risk factors. Let us go now to the modifiable risk factors, which are obesity, level of physical activity. So the patient who is having physical activities more, they will have less cancer. The alcohol consumption, as it increases, it will increase the risk factor, it will increase the risk of the breast malignancy. And exposure to exogenous estrogen for premenopausal and exogenous progesterone for postmenopausal. Pathology of breast cancer. The breast cancer will not start at once. It needs period, and during this period, there are several steps that the cells of the breast will go through changes to reach cancer. So if we take cross section in the duct, or we take cross section in the alveoli, we will have two layers of epithelium. As we see here, we have the luminal cells or epithelial cells and myoepithelial cells. This is the second layer, this is the first layer, and we have the basement membrane. If we have more than one layer of epithelial or luminal cells with benign feature. We call it hyperplasia without atabia. So this is the first change which will happen. The second change which we will have is abnormal layer of cells with some malignant features, but these cells doesn't fill up all of the lumen of the duct or the acini or alveoli. We call it here atabia, hyperplasia with atabia. If these atypical cells fill up the whole lumen, here we call it DCIS. If these cells invade the basement membrane, we call it invasive cancer. So according to the cell type, we can call it ductal carcinoma in situ or lobular carcinoma in situ. And this in situ, it didn't cross the basement membrane. The breast cancer pathogenesis and histologic versus molecular subtypes is here very clearly. We have here, as we said, we have luminal cells and we have myoepithelial and the basement membrane. Between these luminal and the myoepithelial cells, we have progenitor cell, which will give rise to this myoepithelial or to the luminal cells. So it is the stem cell or progenitor cells. The cancer can rise at any of these type of cells. Either will come from the myoepithelium, or will come from the stem cells or progenitor cells, or it will come from the luminal cells. In the luminal cells, we have two types actually, which is luminal A and luminal B, and these subtypes divided according to the amount of the estrogen and progesterone receptors. And those types of cells, type of cancer, actually are the most common, and they have ER, PR positive, estrogen receptor positive and progesterone receptor positive. This type of tumor is low grade and it has very good prognosis and will respond very nicely to the endocrine therapy, because endocrine therapy will block the receptors, so it will decrease the division of the cell, and will increase the survival rate of the patient. So this is the first type, which is the luminal type, which is A and B. If it comes from the progenitor cell or from the stem cell, it can give some new features, which are HER2 positive receptor and slightly estrogen progesterone receptor positive. This type is more aggressive than the previous two, and it will respond very nicely to trastuzumab, which will block the HER2 receptors. The HER2 receptors actually it found in most of the luminal cells, but the amount which you will find it in the basoluminal type of tumor, the amount is hundreds or maybe thousands. The third type is the basal cell tumor, which comes from the basal cell, and this is actually progesterone negative, estrogen negative, and HER2 negative, and this is the worst in the prognosis, and it has very high grade tumor, but will respond to chemotherapy more than others. Here we can see the distribution of the tumor subtypes. So this classification actually it depends on the molecular pattern of the cells. There is another classification which will depend on the morphology of the cell rather than the biochemical markers. And this morphology will be either ductal carcinoma or lobular carcinoma. And it will be either invasive or non-invasive. Invasive if it crossed the basement membrane, as we said before, or non-invasive if it didn't cross the basement membrane. And the most common type is the invasive ductal carcinoma. And we will go to general classification of the breast cancer actually, which will show us the general classification regardless the type of the pathology or with the type of pathology. So the first classification is according to the cause. Either it is sporadic, which represent 90%, or hereditary, which represent 10%, and hereditary can be due to BRCA1, BRCA2. We can classify also breast cancer according to the invasion, either invasive or non-invasive, or according to morphology, as we said, not otherwise specified, which is the invasive ductal carcinoma, or specific types like lobular, medullary, mucinous, papillary, or tubular. We can also classify it, as we said, according to the molecular pattern. Luminal type A and B, they have ER/PR positive, basal or basoluminal. How does a patient with breast cancer present to you to the clinic? So the patient will present with one of these symptoms or more than one symptom together. In the area where there are screening program, patient might present to you only with microcalcification found in her mammogram or abnormality in her mammogram. Patient can present with breast mass or axillary mass. Breast mass with axillary mass or without, or axillary mass with breast mass or without breast mass. The patient can present with nipple discharge. The nipple discharge, which is suspicious for malignancy, is bloody, unilateral, or serous, also unilateral. The patient can present with mastalgia, and the most common type of mastalgia is pinprick sensation, and it is rare. Or the patient might present to you with metastatic symptoms like backbone pain or other type of metastatic symptoms like cough, shortness of breath due to lung metastasis, abdominal pain, abdominal mass due to liver metastasis or ascites, distended abdomen due to ascites, or the patient might present to you, which is very rarely to present, with the hypercalcemia only. So you have to be cautious. Any of these symptoms comes to you in the clinic, you have to think about the breast cancer, and you have to prove that by workup that this patient doesn't have breast cancer. Physical findings. Most of the patients with breast cancer will present to you with firm to hard, non-tender, discrete, fixed lump in the breast or axilla or in both. Here we can see, here we have breast lump in this lady. Inflammatory breast, like an inflammatory breast cancer. This is another finding, and we can see it in this lady. Nipple retraction due to fibrosis and inflammatory process, which will combine the malignancy underneath the nipple and will retract the nipple down. And this is, we can see it here. You can see that the nipple is retracted inside. And in the nipple retraction, we have to differentiate the malignant from the benign. This is circumferential retraction, which is malignant, and here we have slit-like retraction, which is benign due to inflammatory process due to any other cause. And so this is benign, and this is malignant type of retraction. BD orange, due to inflammatory process and edema of the breast, it will show like the skin of the orange, and when there is edema in the subcutaneous tissue, it will make the area of the sweat glands and sebaceous gland to be tethered inside. So you can see it like peel of the orange or skin of the orange. In the Paget disease, the patient can present to you just with scaly nipple or destructive nipple, like here. Such patient, she will come to you and you think that it is just dermatitis. You will give her cortisone, then later on she will come with this picture. The nipple will be destructed, and this is due to underlying tumor which comes out and destruct the nipple through the duct. The patient might present to you also with metastatic signs. How can we work up a patient with the breast cancer? We have three things which we have to do it in any patient who present to you with lump in the breast. And this is actually which we call it triple assessment: clinical, radiological, and biopsy. Clinical history and physical examination and risk factor assessment. Radiology, mammogram for any patient more than 35-year-old. And ultrasound for any patient who present to you with breast symptoms. MRI actually is very sensitive, but not specific for cancer. So it is reserved for patients who have unclear diagnosis, while she is very high risk, like patients who have BRCA1 or BRCA2. Once you see the mass, or you feel the mass, or the mass diagnosed to you by the radiology, according to the radiological features, you will do for the mass biopsy or histopathological assessment, and this should be done by core needle biopsy, either bedside if it is palpable. If it is not palpable and seen by ultrasound, you will do ultrasound guidance. If it is not seen by ultrasound but seen by the mammogram, you can do which we call it stereotactic biopsy. If you cannot see them by ultrasound or stereotactic biopsy, you can do for them MRI guided biopsy. And this is what we call it triple assessment. So this is the general approach. We just talk about it. We will not go through it. But here, after diagnosis, this is the general approach how to manage the patient. After diagnosis, you have to stage the patient, and this is really applicable for any patient with cancer. And then you will go for management, because most of the management depend on the staging. Steps for staging after diagnosis. First, you have to start with CT chest, abdomen, and pelvis with contrast. Bone scan for bone metastasis. And you have to do for the patient, which is not related to the staging, the routine investigations to prepare her for OR or for other treatment like CBC, LFT, renal function tests, calcium and alkaline phosphatase, because some patients, as we said, can present to you with the hypercalcemia or metastasis to the bone, which will increase the calcium and it will increase the alkaline phosphatase. Tumor markers should be done as a baseline for follow-up of the patient later on after the treatment. So you'll do the CEA for the patient, and you'll do cancer antigen CA15-3. After that, you will stage the patient according to the staging what we have here, and then you will put the patient on the table of the TNM classification: T for the tumor, N for the lymph node, and M for metastasis. After that, accordingly, you will see, is the patient early breast cancer, locally advanced breast cancer or metastatic breast cancer. So you will treat the patient according to the stage. Let us first start with non-invasive cancer, which is ductal carcinoma in situ. The most common presentation of the ductal carcinoma in situ in the screening programs area is the microcalcification. And this is a really early detection of cancer. As we said, it will start as DCIS, then it will be invasive. The most common presentation in area where there is no screening programs, either bloody nipple discharge or serous nipple discharge also, or lump. So the treatment is depend on the size of the tumor. If it is localized, then you will do lumpectomy with free margin. If it is diffuse or very large area involved with the DCIS, then you will do for the patient mastectomy. The lobular carcinoma in situ, it is just a risk factor rather than a disease itself. So how could be diagnosed? Usually we find it as incidental with biopsy for another region. So the patient come to you with specific complaint, you did for her biopsy, and then you find that with the biopsy there is LCIS. This just will increase the patient's risk. So if I have a patient with the LCIS, how can I manage this such patient? Either with follow-up every 6 months and self-assessment every month, or chemo prevention by tamoxifen, because most of the LCIS are ER, PR positive. So if you give the patient tamoxifen, this will regress those type of tumor by blocking of the receptors, and then will decrease the risk of malignancy. And the last but not the least, you can do for the patient prophylactic mastectomy and reconstruction, and this is depend on the patient's request. In the early stage breast cancer, you will start with surgery, then you will give the patient adjuvant systemic therapy, and then you will send the patient for radiation. And as we know that breast cancer, it will not be treated only by one man. It is teamwork, and this will be done by multidisciplinary team, which consists of surgeon, oncologist, and radiation therapist, sometimes psychologist or psychiatrist to help the patient, and also plastic surgeon. The treatment in the early breast cancer, the surgery, the patient can undergo mastectomy and axillary dissection, which we call it modified radical mastectomy, if the tumor is big, or the tumor is more than 20% of the volume of the breast. Or the patient can go for breast conserving surgery, which is lumpectomy and axillary dissection, according to the patient stage, which is the early stage. Those patients, all of them should go for radiation after they receive adjuvant systemic chemotherapy. In patients who they underwent modified radical mastectomy, they will go just for chemotherapy. There is no radiation for such patient. Lumpectomy is, or breast conserving surgery, taking only the lump which contain the malignancy, and the mastectomy, as we see here, modified radical mastectomy. What are contraindications for breast conserving surgery or conservative surgery treatment? Previous history of radiation if the patient having radiation, because as we said, all patients with breast conservative surgery, they should go for radiation. So if the patient get radiation before, cannot go for radiation again. So the patient will not have a chance to get only lumpectomy. If the tumor is more than 20% of the breast volume, because if you take it, you will have no breast, just disfigured thing in the area. If the radiation is required during pregnancy, pregnant lady cannot get breast conserving surgery if the time of the radiation according to her therapeutic plan will be included in her pregnancy, so the patient cannot receive radiation while she is still pregnant. Diffuse malignant appearing microcalcification or inability to achieve negative margin due to widespread breast disease. Also, patient preference. Some patient will tell you that I don't want breast conserving surgery, just do for me mastectomy and the reconstruction. In the locally advanced cancer or inflammatory breast cancer, we don't start with surgery. We start with new adjuvant systemic chemotherapy, either chemotherapy or hormonal therapy according to the patient cell subtypes. Then the patient will go for not less than modified radical mastectomy. And then the patient will go for radiation. And the metastatic breast cancer, the patient will go for palliative chemotherapy only. Will not go for surgery, except in specific situation. We'll talk about them. Budget disease of the nipple. Actually, here we have to take the whole breast out, because as we said that the nipple will be distracted because of the underlying malignancy. And you will do auxiliary management according to the stage of the patient. If she has metastasis already, you will consider her for palliative chemotherapy. If it is locally advanced, you will take her for new adjuvant chemotherapy. If she is early breast cancer with the Paget's disease, you will give her the treatment of early breast cancer. The prognosis actually depends on two things: the ability of the tumor to metastasize. For example, poorly differentiated cancer will have more ability to metastasize, and this will worsen the prognosis. Or the patient having advanced stage, so early breast cancer will have better prognosis than locally advanced breast cancer, and locally advanced breast cancer will have better prognosis than the patients with metastasis. Complications, we have local complications like mass ulceration like this. If these patients comes to you while they are metastatic, you can do for them toilet mastectomy, just to prevent bleeding from this ulcer. And this is one of the complications. This ulcer can bleed. Patient who have pain should be treated with painkiller. Upper limb lymphedema, because of the blockage of the tumor cells, will block the lymphatics. So the lymphatics coming from the upper limb will not drain to lymphatics. There is systemic complication like paraneoplastic syndrome, which is very extremely rare, and this maybe will present with hypercalcemia. Complications of metastasis like bone pain, respiratory symptoms, abdominal pain, hypercalcemia symptoms, and anemia. Breast reconstruction, the breast cancer, either breast conserving surgery, which will not need reconstruction, or patients who undergone mastectomy, either they will have immediate or delayed reconstruction. And the reconstruction, we have two types of reconstruction: autologous reconstruction or alloplastic reconstruction. The alloplastic you will put here like silicone, and the autologous reconstruction, it is from the patient's body. You will use some muscles like tram flap or latissimus dorsi flap, or you can use other types of flap which we have here like SGAP flap or IGAP flap or transverse upper gracilis flap. Good luck.